Oops, why is this not working? Oh my goodness. It's not advancing. There. Talk a little bit about the different kinds of dementias that are out there. I mean, everybody assumes everything is Alzheimer's, but it's actually not true. There are several different ones that are very distinct. And talk about reversible causes of dementia, review high-risk medications that are one of the reversible causes of dementia. And those are the meds that can contribute to cognitive slippage. So there's going to be a little bit of overlap between what I talked about last time and this time.
Dr. Gurbich, sorry that to interrupt
Yeah.
you, but we are having some audio problems. Can you, I don't know if it's the microphone that is a little far, but we cannot hear you well.
Okay, that's strange.
Or
Can you
I
hear
don't,
me
maybe it's
now?
my computer. Can someone?
Can you hear me now? I'm sitting right next to it. And I was just on Zoom.
I can hear well.
Can you hear
Okay,
me?
good.
Okay. Okay.
Thank you.
All right. So we're going to talk about the high-risk medications. Again, there's going to be some overlap from the previous talk, and then we're going to specifically focus on the meds that are used to treat dementia. And there's a new class of medications that has come out in the last couple of years, so I'm going to talk about that. So when you look at the prevalence of dementia, it's looking like it's on the rise. I mean, these are the different age groups and patients being diagnosed with dementia. And as you can tell, the steepest curve is in the 85 plus. And it's not that dementia has become more prevalent. It's just that I think we're better at identifying it as a disease and also and diagnosing it as a result. There are a number of programs in the state that are focused on training primary care physicians on screening for dementia in older adults and diagnosing it. And so that may be why these numbers are climbing. So this is just kind of interesting. 1 in 9 people at the age of 65 and older has Alzheimer's, so 11%. 1 in 3 age 85 have Alzheimer's disease, that's 32%. So definitely there's an increase in incidence of dementia after age 85. And, you know, in terms of incidence, every 68 seconds, somebody in the United States develops Alzheimer's disease. And by 2020, it'll be every 33 seconds. And I think that just speaks to the fact that our population is aging, and the older we get, the higher the risk of dementia. When you look at dementia in general, it's sort of a progression from normal, from normal aging that's completely appropriate and normal to a stage that's called mild cognitive impairment or kind of pre-dementia. And then you get into the dementias, and they can be mild dementia, moderate dementia, and severe. So it's like a progression of things. So what's normal aging? A lot of people think they have memory impairment when they actually don't. So sometimes patients will have subjective memory complaints. They realize that they're not remembering things as well as they used to. These are generally not disabling, but more annoying to the patient. Sometimes they have issues with retrieval of names, like they could be watching a movie and they can't remember a movie star on the screen that they knew well previously. And then they may have minor difficulties recalling detailed events in the recent past. And some, you know, as we age, speed of processing does slow down. So some of these are normal age-related changes, especially if they're not impacting any kind of a life event or any function during the day. When you get into mild cognitive impairment, this is what happens. You've got either a memory-only problem, so really focused on not being able to remember things that you should, and that's amnestic type. Or you could have disorders in the executive function or planning or logically sort of sorting through problems, and that's non-amnestic type. And most of the time, well, not most of the time, some of the time, MCI does progress to dementia, to a diagnosis of dementia within 5 years. And sometimes it just kind of stays at this mild cognitive impairment stage for much longer, and it's not a long-term problem. Memory deficits are typically minor, or they can be disabling. And I think it has to do whether your MCI is of amnestic type or non-amnestic type. It may be identified because there's improved testing, and not only is there improved testing, there are different screening tools that we have at our disposal to test for this stuff, but also there's more focus on it, so people are getting those screens more often. But for the most part, when you have MCI, patients retain their function, so they're able to do stuff in their daily lives, and this mild cognitive impairment is really not impacting their lives. The other thing you want to think about is delirium versus dementia, very different concepts. So delirium, usually the reason you're delirious is because there's some kind of an underlying medical cause, either an intoxication with a substance or a medication or an infection, or some other medical condition that would cause a delirium. The onset is very sudden. Duration is short. Hours to days. Attention is generally reduced, so there's this inability to focus, sustained, or shift attention, which primarily happens in delirium. Consciousness can be fluctuating, so there may be a reduced level of consciousness. And then there are other features like hyper versus hypoactive, disruption in sleep, duration, and all of that. Dementia is kind of chronic, slow progressing disease. So the underlying cause of dementia is a neurologic process in the brain, and it's very slow progressive. So if you notice all of a sudden a patient is having cognitive impairment and never had it before, chances are it's probably delirium. And so you have to look for a medical reason for it. Sometimes a medication can cause it as well. But usually it's a long and steady process, so duration is months to years. Attention is usually pretty normal until the dementia becomes more severe. Consciousness is generally intact, and other features vary depending on what type of dementia it is. And you can have a situation where you've got a demented patient who gets delirium on top of that dementia. So when we talk about dementia, it's really an umbrella term that describes many different kinds of dementias, Alzheimer's disease being the most common kind. 60 to 80% of our patients have Alzheimer's disease. But there's also Lewy Body Dementia, which most people don't realize that it exists, and we'll talk a little bit about that in a few slides. And then there's vascular dementia, which the primary cause of which is like some kind of a cardiovascular complication or neurologic complication like a TIA or a stroke. Sometimes you get vascular dementias after a heart attack. And a lot of times there's this mixed picture of vascular and Alzheimer's happening all at once. There's also a rare kind of dementia, frontal temporal dementia, which we'll talk a little bit about later, and then other kinds of dementias like Huntington's and Parkinson's, which I wasn't going to cover in this talk. So Alzheimer's disease is primarily a memory problem. So patients typically have problems remembering, having issues with short-term memory and forgetting things that just happened, versus long-term stays intact for a very long time. And they're also less able to learn new information. And then as Alzheimer's progresses, they develop expressive language problems, not being unable to name things, fluency changes, their visual spatial function changes. So like drawing a clock, for example, becomes more difficult. They have trouble recognizing people, objects, getting lost while driving, even in familiar situations. And then executive controls become impaired as well. So judgment becomes impaired. Vascular dementia looks a little bit different. It's primarily a problem. So this is the dementia that happens after a stroke or multiple TIAs. This is with this kind of dementia, people have problems with planning, organizing, making decisions, or solving problems, and something that we kind of do in our daily lives that these patients are now not able to do. They're not able to follow a series of steps. So some of the cognitive screens that we have say, you know, take this piece of paper, fold it in half, and put it on the floor. And so that's a 3-step command, kind of. And patients with vascular changes sometimes can't do that. There's also slower speed of thought and processing. So you give them information and you can tell they're having difficulty following it and understanding what you're saying. There may be problems concentrating, including short periods of time of confusion. So how do vascular patients present? There may be some memory problems. There may be some verbal fluency issues. There may be mood changes associated with all of these changes because patients generally recognize that they're impaired. There may be behavioral changes as a result. They get very agitated. And so one of the ways we have to manage this is with medications, and I'll talk about that a little bit later on. And in very late stages, they actually also can develop hallucinations. Lewy body dementia is much more rare. This is Estelle Getty. She was in one of the Golden Girls. She died with Lewy body dementia. This is kind of a weird dementia because sometimes it starts as Parkinson's symptoms, like patients have movement disorder kinds of symptoms. And then the memory component and the dementia component also comes into play. And sometimes the dementia comes first and then the movement issues come in. But you get visual hallucinations with this kind of dementia much earlier on. You get cognitive fluctuations where you're clear and then become confused again. There's definitely a Parkinsonian component with rigidity, tremor, things like that. You've got autonomic dysfunction, sleep disorders, pronounced visual spatial deficits. And then there's also, it's very unique because you have this sensitivity to antipsychotics. So when they're having hallucinations and you start them on an antipsychotic, sometimes they respond negatively to it. So you have to be very careful in choosing your medications, titrating them very slowly, and really deciding whether the hallucinations are worth treating, because sometimes when you bring in the meds, it makes things worse. Then there is frontal temporal dementia, which is a little bit different. It starts earlier. It usually starts in the late 50s, early 60s. And the prominent feature of this dementia is a personality change, really striking personality change. There's sort of this disinhibition or apathy that occurs. So people do really crazy things, like they will approach you suddenly and grab your sleeve and pull on it, or they will start undressing in front of you, or they will start talking to you completely inappropriately, outside of the social norms. There's less of so there's very impaired judgment and very impaired insight. Less of a memory problem. So they remember things pretty well, especially in the early phases, but they have difficulty in daily life because of this disinhibition and this impaired judgment and insight. It progresses much more rapidly than Alzheimer's disease. And the guy on this page is, I don't know if you know what he looks like, but this is Friedrich Nietzsche, who was one of the philosophers, and he had frontal temporal dementia. I'm sure he had it way before we could diagnose it. So I wonder if some of his philosophies were really impacted by the fact that he was in fact demented. It's kind of interesting from a historical standpoint. So some of the reversible causes of dementia, these are things that we can deal with and fix, right? So metabolic disturbance, so you want to make sure your electrolytes are in order. You want to make sure diabetes, hypertension, hyperlipidemia is under control. Dementia could be a reversible cause of dementia could be a thyroid dysfunction. So you want to make sure thyroid is within normal limits. You want to make sure there's no infection or any other medical concern that's sort of more acute. Anxiety and depression can also sometimes mimic symptoms of depression. So you want to make sure that's adequately treated. And then alcohol, illicit drugs, cannabis, and medications are one of the reversible causes of dementia. We're going to focus on that in a few slides. And then, if people have chronic insomnia and it's severe enough that it impacts, daily activities, I suppose it's one of the risk factors for developing dementia. And then obviously other psychiatric diagnoses. So this is a general workup for dementia. I borrowed the slide from Dr. Tam. He's one of our geriatricians I work with at UCI. So you have to have, you have to have a pretty thorough workup and get an H&P from a patient. So you want to talk about symptoms, daily function. You want to talk about the course of this event that families or patients are noticing. You want to definitely go over medications. You want to look at family history, social history. You want to do an exam, and you want to do a cognitive assessment. And cognitive assessment could be a simple screen, like a mini cog or a mini mental status exam or a MOCA, or it could be more extensive testing. And then obviously you want to get labs to rule out reversible causes. You want to get imaging if that's necessary. And then, if it looks like it's normal aging, you want to reassure patients that it's normal and encourage them to stay as active as possible with exercise, brain activity, sort of staying engaged, and then with obviously regular follow-up. If we're thinking it's mild cognitive impairment, the instructions are really kind of the same, just staying more active, engaged, definitely include exercise, definitely include cognitive stimulation, and also follow-up. And then, if it's mild, moderate, or advanced dementia, then you've got things to do. Make sure you go through the meds. And actually, if somebody has mild cognitive impairment, you also want to look at the meds, because if there are any medications that can contribute to cognitive slippage and we get rid of them, that process could actually be reversed, right? But also, if they have dementia of any degree, you also want to look at the medications. And then you've got a couple of options for pharmacotherapy, and I'm going to go over that in a second. Once dementia is diagnosed, you want to make sure that we're doing everything non-pharmacological that's possible to do. So making sure patients are comfortable, patients are exercising, patients are engaged, they have good caregivers, and caregivers actually understand how to deal with some of the cognitive concerns. I think sometimes patients get very agitated when the caregivers that they have don't understand the disease process, and they start arguing with a patient about, well, I just told you this 5 minutes ago. Why don't you remember? And don't you know you wore this dress yesterday? You can't wear it again today because it's dirty. I mean, patients don't understand that if they're demented. So they're really kind of interesting stories that I've heard over the years. I had a friend whose mother was demented, and she really liked her black dress. And so she refused to wear anything else. So the daughter was smart enough to go buy 7 black dresses, and she would put a new one on every day to eliminate this argument about, I don't want to wear this pink dress, I want to wear my black dress. Another really kind of interesting story, a patient was very active, and before he was diagnosed with dementia, was an avid gardener. And so they needed to get him some kind of an activity because he was pacing and agitated at home. So the psychologist they saw came up with this idea. The wife would go they had a giant tree in the backyard. The wife would pick up the leaves from the tree, put them in collect them, dump them out, and tell the husband, go rake up the trees. He would do that. And 20 minutes later, he would forget that he had done that. So she would dump out the leaves again and ask him to come back to the backyard a couple of hours later so he could get more exercise. So those kinds of ideas of thinking out of the box to ensure that the patient gets their activity and reduce the agitation that way can be really helpful. So let's look at the meds. So some of these slides may look familiar because there's a lot of overlap in what I was talking about before versus this time. So you're looking for polypharmacy, and you're trying to shrink the med list and make it as rational as possible, getting rid of anything that can possibly contribute to cognitive slippage. So polypharmacy is, again, anybody who's they're at risk for polypharmacy if they have 5 or more medications on the list. So you should review the meds, get rid of anything without an apparent indication, get rid of duplicative medications, look at medications that impact the brain, that are centrally active, because the more of those you're on, whether or not they're high risk or not, the more the patient can slow down, can become a little bit more confused and disoriented. So you want to really focus in on CNS active medications, because sometimes the results can be cumulative. You also want to review over-the-counter meds, and in this part of the slide, this is what was similar from the previous talk. These are all high-risk medications. They all have antihistamines in them that can cause cognitive slippage. There are things like belladonna, which is a herbal product that can cause cognitive slippage, also an anticholinergic product. Valerian root, it's a relative of a benzodiazepine. Benzodiazepines are known to cause cognitive slippage. And although valerian root is generally better tolerated than a benzo, if you've got a demented patient, it's not recommended because it can trigger confusion. And then cannabis, we still don't know what cannabis does to the brain. There are very few studies in older adults, and especially in those with dementia. And so potentially this can also contribute to confusion, and alcohol as well. If you have a diagnosis of dementia, you really should be not drinking. Okay. So again, this is an old slide from the previous talk. These are all medications with anticholinergic properties. And the reason you don't want to use them is because in our demented patients is because they can cause cognitive slippage. And there's increased evidence that there's an increased harm related to cumulative exposure. So if one of these medications can contribute to cognitive slippage, multiple of these can make a bigger impact and cause more of a slippage. So you really want to limit the number of drugs in this category if you aren't able to eliminate them altogether. There does seem to be data suggesting that there is an increased risk in dementia, even in younger patients, less than 65, who've been on these drugs for a long time. So be careful when you use OTC sleep aids, because the longer you use them, the higher the risk of you developing cognitive slippage at some point. So the goal is to keep the anticholinergic burden, which is what ACB stands for, to less than 3. Most of these drugs are 3. Some of them are 2 or 1, but most of them are 3. So even a single drug on this table can contribute to cognitive slippage. And what kinds of things are on there? Some old antidepressants are on there, some newer antidepressants like paroxetine, which is just an SSRI, but it has a little bit of an anticholinergic activity. Cough medication, nausea medication like promethazine, for example, or compazine are on there. First generation antihistamines, most of which are over the counter. So Benadryl, diphenhydramine, chlorpheniramine, brompheniramine, things like that. Hydroxyzine, which is a prescription antihistamine. Meclizine, which is often given for dizziness, can cause cognitive slippage. And then all the urinary antispasmodics, when you've got urgency, you get these, and so that can cause confusion. And then some GI antispasmodics, if you have irritable bowel, are also on this list, and then some muscle relaxants. So I don't know if I showed you this exact cascade before, but this is what can happen and how medications can lead to a misdiagnosis of dementia. So you've got amlodipine for hypertension, which is a common way to treat blood pressure. You develop edema. You get a diuretic on board to treat the edema. That leads sometimes to frequency in urination, but in your frail older adult, that can lead to incontinence because they just can't make it to the bathroom on time. And then after that, you get an incontinence medicine like oxybutynin, for example, which is very highly anticholinergic. And then you become confused, and then you come in with memory concerns and you get a misdiagnosis of dementia. So this is how this whole thing can progress. And I've seen this happen in real life. This is not just theoretical. This is parts of the Beers criteria that focus in on cognitive impairment. So you really want to avoid muscle relaxants, benzos, the Z drugs, so things like Ambien, Lunesta, Sonata, drugs with anticholinergic properties, they can all contribute to sedation, cognitive impairment, and fracture risk. Antipsychotics are typically used in to manage agitation or problem behaviors, and I have a slide on them in a little bit. But antipsychotics also have a black box warning saying that if you use these drugs for this agitation, that increases the risk of stroke or death in patients. So when physicians decide to prescribe these drugs that are managing agitation, they have to have a discussion with the patient and especially with the family and the caregivers, explaining to them, okay, we're going to use this, but there's an increased risk that your loved one will die or have a stroke or something similar. So the decision to use these drugs for agitation has to be very carefully thought through, and the behaviors have to be deemed appropriate for this kind of treatment. Dementia meds come up on the Beers criteria when you have to be concerned about them when there's a history of falls or syncopal episodes, because one of the drugs that we use to manage dementia, cholinesterase inhibitors, and there's a slide for them in a few slides again, they increase that risk. So with cholinesterase inhibitors, when you start them for Alzheimer's disease, they can cause dizziness, and people pass out sometimes. And so if there's a fall history, you have to be very careful. And then if, delirium and cognitive impairment, you want to, again, avoid all these. So tricyclics, which have anticholinergic properties. So these are antidepressants with anticholinergic properties. All anticholinergic medications in general, and you have that slide that I just showed you with those drugs on it. And then some antipsychotics also have anticholinergic properties. Steroids can cause confusion, and H2 blockers, these are things like Pepcid. You want to be very careful using them in patients with delirium. So these are the drugs that we use to manage agitation. So things like olanzapine, risperidone, quetiapine, aripiprazole, pimavanserin, and this brand new one, brexpiprazole. This one is the only one of all of these that's actually FDA approved for agitation in demented patients. The rest of them are used off-label. You really want to stay away from Zyprexa or olanzapine because it's highly anticholinergic, and it was on that table that I showed you of drugs with anticholinergic profile. The ones we usually use are things like risperidone, quetiapine. Quetiapine seems to be more sedating than risperidone. So if agitation happens more at night and they need to sleep better, this is a pretty decent drug to try. If they don't need to necessarily go to sleep, you could start with risperidone. But at UCI, we use these a lot, risperidone and quetiapine. Aripiprazole is newer, probably better tolerated, but much more expensive. And so most of your Medicare Part D plans won't cover it, but it is an option as well. Pimavanserin is even more difficult to get covered. It's actually got a fairly decent side effect profile. It doesn't cause has no effect on acetylcholine. It's not terribly sedating, so patients can function during the day on it. So the side effect profile is very different. And then this brand new one, this is the one that was approved for agitation in demented patients through an expedited review. So we're really not quite sure what effect it'll have on older adults. There does appear to be modest benefit when this drug is used. So the trick is when you're looking at somebody with agitation, is to figure out what the actual behavior is and identify that behavior. Because when I'm talking about agitation to a family member or caregiver, my definition of it that I think of as agitation may be very different than the caregivers or the family members. So it's really important to identify specific behaviors. And the behaviors have to be such that they're either a danger to the patient or a danger to the caregiver. So, for example, if the main way a patient exhibits agitation is that they're wandering, they're wandering from room to room and they won't sit still. That's not dangerous. That's exercise. So you have to kind of reframe your idea of it and just say, okay, they're exercising. That's good for them. So provide them opportunities to walk and wander in a safe place where they can't, if they're in a house, they can't elope. If they're outside, they can't trip over something dangerous and harm themselves. But walking is good. So that's not worth medicating. If they're pulling caregivers' hair, if they're spitting at them, if they're spitting out their medications and preventing care from being administered to them, that would be considered a danger to the patient or to the caregiver. So you really have to identify those behaviors very carefully and only medicate those that are a danger to either the patient or the caregiver. You also have to monitor efficacy because a lot of times you start these medications and the behavior persists. If the behavior persists and we've maxed out on the dose and the doses are provided here, you really want to like re-strategize. Okay, this didn't work. Let's try something else. You don't want to just pile medication on top of one another. And again, because there's a black box warning for all these drugs for an increased risk of stroke or MI, you want to have a discussion with the family that this is potentially a risk. So we're only using it as a last resort. So all those non-pharmacologic approaches that social workers and psychologists are so great at coming up with, that they should be employed. I was just talking to a daughter of a demented woman last week in my clinic, and we were trying to figure out which antipsychotic to use because the mom was really agitated at night. And when I started asking her about what exactly was going on, she said, well, she takes off her pajamas and she wants to make a skirt out of them. And she wants to do it in the middle of the night, and she has 24/7 caregivers. I'm like, okay, well, if she wants to make a skirt out of it, why doesn't the caregiver help her make a skirt? Buy more pajamas. That's not a dangerous behavior. The only inconvenience is that the patient is up at night doing this. And that happens a lot when they get demented, they get night and day mixed up. And so they're up at night a lot and they sleep more during the day. And if you're paying for 27 caregivers, that's what you pay them for, to take care of this older adult, right? So that's not a dangerous behavior. The other thing the caregiver would argue with this woman about is when she wanted to go outside for a walk, and she wanted to put on a shower cap on her head before she went for a walk. And the caregiver would, do a tug of war with this stupid shower cap, and the patient would get excessively agitated. Again, that's not a dangerous behavior. If she wants to put on a shower cap, let her put it on. Let's walk outside. She might forget that she has it on in a few minutes, and then you can gently take it off and she won't even realize it. So you kind of have to deal with this stuff as you would with an ordinary child sometimes. Picking and choosing what you're going to react to and what you're not going to react to, because medications carry inherent risks, and so these really should be the last resort. So let's get into meds that actually impact cognitive decline or slow it down. So you've got three options. You've got cholinesterase inhibitors, which are sort of the oldest medications that we have at our disposal. And these work by increasing the amount of acetylcholine in the brain, which is thought to improve neuronal transmission. And these drugs have been on the market for over 20 years. The next set of drugs we have, they're called NMDA blockers. And these drugs impact glutamine dysregulation or prevent glutamine dysregulation, which happens with Alzheimer's disease. So there's glutamine kind of goes haywire and becomes overactive, and patients get very agitated. And so they sort of block glutamate production, and so patients calm down when they're demented. And then the last group of drugs are these brand new things that have hit the market a few years ago, and they're all over the news. And these are monoclonal antibodies. And what they do is actually they go to the source. They remove amyloid beta plaques and tau proteins, which are the hallmark of Alzheimer's disease. So they actually go to the source of what the pathology is. So these are cholinesterase inhibitors. There's 3 on the market, and they're all mechanistically, they're kind of similar. The ones that we see the most are donepezil, which is, the brand name is Aricept. I don't know if you've ever heard this drug. And then the other one is rivastigmine, which is Exelon. Donepezil is an oral pill. I think it also comes as a patch, but that's never covered. It's easy to use. You start with 5. If they tolerate it at 5 for about a month, you go up to 10 and you're kind of done. There's a high dose donepezil, which is available at 23 milligrams, but that's more side effects than efficacy, so you usually don't use that. And rivastigmine comes in pills and patches. Patches are significantly better tolerated. So if you're going to use rivastigmine, I would recommend a patch. But in terms of differences between rivastigmine and donepezil, they're very similar. So they kind of can be used interchangeably. And then there's galantamine, which is twice a day drug, and it's generally not, I haven't seen it used in a long time. So those are kind of, these 2 are probably the most commonly used drugs you'll see. So what are their side effects? So because these drugs increase acetylcholine production, or actually prevent acetylcholine breakdown is what they do. So they increase acetylcholine levels. They will have cholinergic side effects. What are they? Diarrhea is one. Nausea is another. They could have vomiting. They could have weight loss. And the percentages are listed on the slide. You can also have a slowed heart rate, and that could be particularly a problem if they're already on like a beta blocker for their CHF or something that also lowers heart rate. So you could actually get into a bradycardia situation, or a heart rate less than 50 is when we start to really worry. They can cause dizziness and syncopal episodes, and that's why cholinesterase inhibitors are on the Beers criteria. They can have sleep disturbances. You can usually have really vivid dreams, and sometimes excessive somnolence during the day. So usually you give it at night. You can get frequency in urination, which sometimes becomes incontinence. And you could have this sort of allergic looking picture, runny nose, watery eyes, sometimes drooling, and headaches. So some of these side effects are showstoppers. Like if somebody has chronic diarrhea and they're incontinent because of it, that's a problem. If they've got urinary incontinence, urinary incontinence and fecal incontinence are the most common reasons for institutionalization of a demented patient. So these side effects do happen at enough frequency that it's a problem. So some of the things to think about. So all cholinesterase inhibitors will do is slow down the progression of the disease. So the benefits that patients or families see are relatively small. Oftentimes they see no change because it doesn't reverse the dementia, it just slows the progression down, right? So if they see no change, presumably the drug is working. And sometimes, in fact, when they see no change and they want the medication stopped and we discontinue it, the patient gets significantly worse pretty quickly. So if there's no change and they're tolerating the medication well, the recommendation is to stay on it. The effects on cognition are fairly mild. Again, they won't improve memory, they will just keep it steady. So the earlier you start this medication, the more effective it may be because it'll keep the patient more less demented for a longer period of time. It may improve a little bit of independence. It may allow them to do their activities of daily living a little bit more independently for a longer period of time. If you look at how effective it is, generally speaking, it delays nursing home placement by about a year, usually. So some things to think about. Again, GI symptoms are pretty prominent. So patients, you want to make sure the patient doesn't lose a lot of weight with donepezil, which sometimes happens late into therapy, which is why in later stages, we may consider discontinuing. It can cause urinary frequency or incontinence, which is a huge quality of life impact. It does slow the heart. And the duration of therapy is really variable, but if the patient is stable and tolerating it well, the recommendation is to continue. And you want, because these are because these drugs increase acetylcholine levels, you certainly don't want to have anything on the list with anticholinergic properties. And that's why we talk so much about these anticholinergics and to avoid them in dementia. The second drug is memantine, which is an NMDA blocker, and its role in therapy is kind of secondary. So it's usually given in more advanced dementia. So moderate to severe dementia is when usually memantine is initiated. And again, it does the same thing. It slows down the decline of function. It slows down the decline of loss of activities and, especially activities of daily living. So, and sometimes it's used in combination with a cholinesterase inhibitor. Sometimes it's used alone, depending if the patient can tolerate a cholinesterase inhibitor. The dosing is usually, you start with once a day, then you go up by 5 milligrams every week until you achieve 10 milligrams twice a day. There are also extended release formulations that are once a day pills. And this drug does have to be renally adjusted. If kidney function declines, the maximum dose is 5 milligrams twice a day. It's generally much better tolerated than donepezil. So sometimes it causes agitation. So when you start this medication, you always want to make sure the patient doesn't get worse. So that's something to look for immediately. It can cause diarrhea, but not as much as donepezil. It can cause insomnia sometimes, some dizziness, some headaches, and some hallucinations, but generally speaking, less of an issue than some of the side effects you see with donepezil. And so this is kind of what happens with early treatment of these of the disease. You get kind of more time with the patient, more quality time. So the patient declines less rapidly, where with no treatment, you get a sharper curve where there's a sharper decline. And if you start treatment late in the game, you don't get as much benefit as you do when you started early. So that's kind of what this illustrates. So brain protection is more feasible than brain repair. So it's not going to repair anything that's already happened, but it'll protect the brain for a longer period of time from damage. So the last set of drugs that have just recently come out are called monoclonal. It's a class of drugs of monoclonal antibodies. And what they do is they specifically target amyloid beta plaques and tau proteins, which occur later in the disease, but are connected to beta amyloid plaque production. And these drugs prevent or destroy the beta amyloid plaques that are already in the brain. So they go to the actual pathology of this disease. So the current disease model is that amyloid beta plaques trigger tau pathology, and tau manifests themselves in later stages, leading to Alzheimer's disease progression. So this is what beta amyloid plaques look like on imaging, and this is what tau protein looks like on imaging. And the overall strategies, by lowering the levels of amyloid beta plaques, you're reducing the progression of Alzheimer's disease, and you're actually allowing patients to be more functional, at least in theory. So there are 3 medications in this category so far. The first one came out sometime during the pandemic. I want to say 2021, 22. This was Aduhelm. It made a big splash very quickly, and now it's being discontinued. So it's discontinued in January. They discontinued it in January 24, and you'll stop being able to get it from anywhere in a couple of days. So this is out of the picture. You've only got 2 things left. You've got Leqembi, which has been around for a couple of years, and you've got this brand new drug, which is called Kisunla, or donanemab, which is just coming out more recently. And the only people who qualify for these medications are patients with mild cognitive impairment Mild dementia only of the Alzheimer's type. So if you have mixed dementia, which is a very common diagnosis of Alzheimer's and vascular, you do not qualify for this medication because of its side effects. So the exclusion criteria for these trials is very extensive. You can't have significant cardiovascular disease. You can't have any kind of an arrhythmia that would require a blood thinner, an anticoagulant, new one or old one. You know, the criteria is really, really strict to just have patients with some kind of a cognitive impairment of the Alzheimer's type. So again, mild cognitive impairment, mild dementia, not more advanced dementia, moderate or severe dementia. Those patients don't apply. So this is how these guys compare. So this is lecanemab and this is donanemab. So lecanemab came out in 2023. The new one just came out in July of 2024. They basically do the same thing. They target amyloid beta plaques and they break them up. They break them up in different locations of the plaques. So the new drug is more directed at a particular site of these amyloid beta plaques. And lecanemab is more generally, it just generally breaks them up. The major difference in dosing, I mean, they're both IV, so you have to have an IV, they're done by IV infusion, and they're usually done in the hospital, and they're only done in neurology departments, like in geriatrics. We don't touch these drugs, we send them to neurology. And the dosing is either every 2 weeks or every 4 weeks. So an apparent advantage of this new drug that came out is that it's every 4 weeks versus every 2 weeks. And the doses are listed. The dose is steady with lecanemab, and the dose goes up from 700 milligrams to 1,400 milligrams after 4 weeks. And these are how long the trials were: 18 months for Leqembi and 6 to 18 months for the new drug. This is what they looked at when this is from clinical trials. So they looked at some kind of they looked at tools that assess the severity of Alzheimer's disease. So I'll show you what, and they're just different things. There's CDR, sums of boxes, and then there's ADRS, which is the Alzheimer's scale, and that I'll show you what that looks like. And the trial sizes were very similar, in terms of number of patients. The duration of treatment was also very similar, 78 or 76 weeks. Slowing of disease efficacy was fairly similar. So 27% with lecanemab, 22 to 35% with the new drug. The biggest difference is the side effect profile. And look, the side effect profile, and I'll talk about the side effects in the next slides. The side effect profiles with the new drug is significantly worse than with Leqembi. Infusion-related reactions, which are just what it says, the reaction around the injection site or the IV site, is much more likely to happen with lecanemab than with donanemab, but those are fairly easy to deal with. So this is the kind of test that they give these patients. So this is the IADRS test, which looks at Alzheimer's disease progression. So they look at memory, language, orientation, attention, planning, and execution. They look at the patient's functional ability, whether they're able to do some of their IADLs or instrumental activities of daily living here or not. So they're tracking all that with these drugs. So what are these side effects? They're called amyloid-related imaging abnormalities, or ARIAs for short. And what they are is these things that you can observe on the MRI. So with this treatment, you have to have pretty frequent MRIs to look for these ARIAs. You got two kinds of ARIAs. You've got ARIA H, which stands for hemorrhage, and ARIA E, which stands for edema. Hemorrhage is more common than the edema, and they spontaneously occur in patients with Alzheimer's disease when they're on this, and also when they're on this medication. And the reason these ARIAs are a problem, because it appears that these monoclonal antibodies, these drugs that are used to treat Alzheimer's disease, they accelerate the breakdown and the clearance of beta amyloid, and because that process is accelerated, they disrupt the vascular integrity and result in either hemorrhages or edema. Usually these areas are asymptomatic, which is why you have to have just periodic scans, whether or not you're having symptoms. But they can present clinically, and they can be life-threatening. Because, a brain bleed is a life-threatening condition, right? So this is what they look like on imaging. This is what edema looks like, and this is what hemorrhages look like. And this is how they present clinically. So patients have headaches, more confusion, visual changes, dizziness, nausea, gait disturbances, and seizures. This is how they present if there's a clinical presentation of it. And the only monitoring we have is monitored through MRIs. So typically patients are scheduled for MRI scans before the infusions, after the infusions. And for lecanemab, for example, MRI scans are done at the 5th, 7th, and 14th infusion routinely. They're also looking for, when they start these medications, they also genotype their disease. And if they have a genetic component of the ApoE4 genotype, that's a genetic variant, there's a stronger association for ARIAs in those patients. So if you have that genetic marker for Alzheimer's disease, you're more likely to have the side effects from these drugs. The cost is huge. For lecanemab, it's $26,000 a year. For the new drug, it's potentially more for an 18-month treatment. Medicare Part B, so because it's an infusion, it doesn't go through drug plan, it goes through Part B. They cover 80% of the cost. If patients have supplemental insurance, they may have additional help, but estimated out-of-pocket cost is about $6,600 a year. And it's expensive, not just because the drug alone is expensive, it's because it's in an office, it's kind of a procedure, and then you have to have all these MRIs routinely. And that significantly adds to the cost. And this is the schedule for donanemab MRIs. So you get it prior to the 2nd infusion, 3rd, 4th, and 7th infusions. What are some of the other options? People always want to take supplements, and there have been some companies that have been sued for misrepresentation of actually, they claim to be effective and they're really not. These are some of the selected supplements that we can use in Alzheimer's disease. So B12 is one of those vitamins you really want to make sure patients have adequate amount of. B12 generally has a very long half-life, and it's pretty difficult to get deficient in B12. But as we age, the absorption of B12 significantly diminishes. So people with dementia will often have low B12 levels. And B12 is associated with neurologic function, and low levels can lead to cognitive decline. So the level you want to maintain generally is above 300. And so a lot of dementia patients are either supplemented by mouth, 1,000 micrograms daily, or if there's really serious absorption problems, then they have to have monthly injections to maintain normal levels. There's been some association between low levels of vitamin D and incidence of dementia, but it's really not conclusive. Replacing it doesn't really reduce the risk of dementia, but it does improve bone health. So we recommend sort of typical bone health protocols for vitamin D, 1,000 to 2,000 to maintain a normal level. And if their levels are super low, you give them a high dose vitamin D for 12 weeks, get it above 30, and then give them a maintenance. Vitamin E, there may be some neuronal protection occurring with vitamin E, but the data is very mixed. I think it depends on the formulation and the source and all of that kinds of stuff. And the biggest risk of vitamin E is it can cause bleeding and bruising. And so if patients are on anticoagulants, for example, or on aspirin, it really increases, or omega-3, it really increases that risk. So currently it's not recommended. And the studies for in demented patients were done in 1,000, using 1,000 units BID, and it's a very high dose that can certainly increase the risk of bleeding. Then you've got omega-3, which is supposed to help with neuronal signaling. And again, there are mixed results. And again, the biggest concern is risk of bleeding. Omega-3 is also pretty good at lowering triglycerides. So if somebody has high triglycerides and they have vascular dementia, it's probably a good idea to use omega-3. But if you don't have a specific indication like that, they just recommend eating omega-3 rich foods 2 to 3 times a week. And again, it's okay to use it in pill form if you're managing triglycerides. So salmon is rich in omega-3, so you want to eat fish 3 times a week. And then there's ginkgo biloba, which the mechanism is it inhibits neurotoxicity induced by beta amyloid plaques. It improves blood flow and decreases platelet aggregation. And again, the biggest risk for ginkgo is bleeding. And it's really difficult to translate the kind of product they use in a clinical trial where it may show some efficacy and buy the exact same thing in an herbal store. I mean, there's no regulation of this stuff anywhere, so it's hard to, or at least in America, and it's hard to get the same product that was used in the trial that showed that it was effective. So currently we don't recommend it because there's an increased risk of bleeding. So just to sum it up, you do want to review meds because the medications are one of the causes of reversal that can be reversed. So you want to look at prescription meds with anticholinergic profile, medications that are psychoactive that can impact cognitive function. You want to look at anticholinergics. You want to review over-the-counter meds, herbal products, cannabis. There's no definitive answer on cannabis yet. There isn't a good study that shows cannabis is effective, and there isn't a lot of information on showing that it causes cognitive damage. But it's just kind of an unknown quantity right now. So the general recommendation is not to use it. You do want to look at meds, screening for medication cascades and looking for those, polypharmacy kinds of situation. You do want to manage all the comorbidities that are sometimes seen in dementia patients. So insomnia, depression, anxiety needs to be treated effectively. There has to be, you want to make sure your thyroid function is normal. There are no vitamin deficiencies. If they have vascular dementia, you want to minimize cardiovascular risk, so blood pressure needs to be controlled, lipids need to be controlled, diabetes needs to be controlled because that increases the risk of strokes and future heart attacks. Adding medications for dementia specifically may be appropriate because they do slow down the decline, but there are obviously side effects that all of them have. You do want to monitor progression. You want to monitor and manage problem behaviors non-pharmacologically if possible. And then the other big thing is providing caregiver education on how to manage these behaviors and how to deal with your demented loved ones and to kind of manage expectations. There isn't a single drug out there that will cure this disease or make it better. It just slows down the progression. Any question?
We do. We have 2 questions. I don't know. Dr. Radam was asking if you should show again the image of the brain, but I don't know which one was that one. I guess is that the one, Dr. Radam? I don't know if she's still here.
Yes, yes.
You can have these slides. Do you want me to? I mean, Delmi has the slides. You're welcome to have them.
So do you have any specific question about these images, Dr. Radam? I guess that we cannot hear. If you are talking, we cannot hear you. But then we have another question, and is regarding what about melatonin supplements to
So melatonin is good so a lot of older adults with dementia have night and day mixed up. So melatonin is one of those agents that can regulate that. So melatonin levels generally fall as we age. So as we get older without dementia, we tend to sleep less during the night and more during the day. And the older we get, the more that switch happens. So melatonin is fine. We use melatonin a lot. It's actually first line for insomnia in older adults in general and those with dementia. Sometimes it doesn't work. So the important thing with melatonin is you have to work with the dose. So starting dose is anywhere from 1 to 3 milligrams, and the maximum dose is anywhere from 10 to 15. So you do want to work with it. So if you're getting partial response to a lower dose, I would recommend going up on the dose. There's also Rosarum, which is it's pharmaceutical grade. So melatonin is an herb, right? Depending on where you go and buy it, you really have no idea what's in that product. It may be melatonin, it may be varying amounts of melatonin, there's no guarantee. There's something called Rosarum, which is pharmaceutical grade melatonin agonist. So it works like melatonin, but it's a drug. So that's also an option. So if you're getting partial response from melatonin, that might be worth trying. Sometimes, depending on insurance, you have to do a prior authorization to get it approved, but that's an option.
It was my understanding that melatonin will be just to induce sleep. Is
So
that
what it does is it shifts your circadian rhythm. So your circadian rhythm gets messed up with age, right? So you're awake more at night and asleep during the day. So melatonin increases levels increases levels of melatonin, right? Because you're replacing it, and it allows you to fall asleep when it's appropriate to fall asleep.
okay?
It doesn't always work. And I mean, of all the things to worry about, I mean, it's usually an issue for caregivers because caregivers don't want to stay up all night. So you just have to kind of decide whether it's worth treating. I mean, I can tell you personally, I have a dad who's demented and he lives 2 blocks away from me and he's got 24/7 care and he doesn't sleep well at night. He sleeps a lot during the day. I don't medicate him. I pay the caregivers to be up with him when he's up. And as long as he eats his meals and goes for a walk every day, which he's still able to do, I don't care if he takes long naps during the day. So you just have to decide, what you're going to pay attention to and what you're not.
Thank you. Dr. Mulligan? You are mute, Dr. Mulligan.
Thank you very much, Dr. Gerbich, for quite an informative lecture. I did have one question that I've been noticing as I look up various medications, that they no longer call these concerns black box. They're just calling them black or box warnings, and they're not putting them, highlighting them.
Yeah.
So why are they doing that? Because it's very easy to miss that concern that we've been seeing all along. Why have they taken this change?
So I can't speak for the pharmaceutical companies. I mean, if you want to be really cynical about it, these black box warnings were very obvious. And when physicians saw them or any provider saw them, they were really scared to prescribe them. And now they're a little bit less conspicuous. So maybe it'll make people prescribe them more and they'll make more money. I have no idea why they changed it. They do have to point to them in the package insert. How they do it is, I think, up to them. I know there are lots of drugs with black box warning, like Toradol, for example. Toradol is an NSAID, just like Motrin and and naproxen and all of those. but it causes significant amount of GI bleeding, where to a point where you don't want to use it for more than a certain number of days in a row. And when first the black box warning came out, everybody knew about it, and Toradol use really got curtailed. Now people don't realize it's there. So I don't know why they've done that. I think I'd like to think it's not because they want to make more money, but I don't know.
Thank you.
Any other questions? No?
There is
Well,
another question said, are there side effects for melatonin?
we couldn't hear you. Delmi, can you repeat the question, please?
There is another question that is said, are there side effects for melatonin?
From melatonin, sometimes you get vivid dreams. So, and that's a dose-related kind of side effect. So that's something to look to keep in mind. And you can get also vivid dreams from donepezil too. So kind of manage that. But overall, melatonin is pretty safe.
Well, thank you, everybody, and especially to you, Dr. Gorbich, for providing us another lecture and a great review about all these medications.
Thank you very much.
We may see you again in the future.
Anytime.
We may not. Stay tuned.
Thank you.
Thank you.
Bye.
Bye.